All right, good morning, everyone, and welcome to our hearing today on health information technologies, administrative perspectives, and innovation and regulation. Thank you for being here. Today we convene the Subcommittee on Oversight and Investigation to discuss development and innovation in these technologies, particularly mobile medical applications or apps, and how federal regulations may impact this growing industry. We're joined by two witnesses from the administration, Dr. Farzad Mostashari, and who is the head of the Office of National Coordinator with HHS, and Christy Foreman, who is the director of the Office of Device Evaluation within the Center for Devices and Radiological Health at the FDA. Both of these agencies have been leading the government's response to the rapid changes that new technologies are making to our nation's healthcare system. On March 4th, this committee sent a letter to the FDA on its approach to regulating the rapidly growing market for applications used on smartphones and tablets. With this explosive growth, the use of those apps to monitor health information is growing, as well as increasing in accuracy and technological sophistication. News reports indicate that there are as many as 40,000 medical applications in the market for smartphones and tablets. We're here today to discuss the discretion FDA has in regulating these apps as devices under the Food, Drug, and Cosmetic Act. And over the last few days, we've heard a number of examples of medical apps and concerns from apps companies about whether these apps are devices. For example, where does an app that transmits photos of potential skin cancer or the healing of surgical scars cross the line to FDA scrutiny? If an app that turns a smartphone into an ultrasound can be regulated, what about apps that let you review images from ultrasound or x-rays? You know, there's been incredible advances in all these things, and we expect to see more. Not only areas of dermatology and use of photos, endocrinology with monitoring blood glucose levels, x-rays with radiology and orthopedics, heart monitors with cardiology, mental status tests with neurology. The list goes on and on. In 2011, the FDA issued draft guidance on how the agency planned to regulate mobile medical applications. FDA has not yet issued final guidance. To our witnesses from the FDA, over the last 2 days, we've heard from a variety of witnesses and members on both sides of the aisle, and the message was clear. We need final guidance. The developers of these apps in the healthcare industry need certainty. That certainty is also needed because of the tax on medical devices put in place by the new healthcare law. As we've heard this week, a tax on medical devices can make capital needed to develop these apps and new breakthrough technologies more scarce. This can slow innovation. And we're caught in the cycle of the snake eating its own tail, whereby we raise tax on medical devices, thus increasing the costs, and then use those taxes to subsidize the increased costs, and offer tax incentives to cover R&D. Doesn't quite make sense, but we want to make sure we're not slowing innovation. So this isn't about scaring people into thinking this tax will apply to their iPhones, BlackBerries, or iPads, but this tax could absolutely halt the development of new apps to run on those devices. Everyone here recognizes the need to balance patient safety and innovation. I hope that today's hearing will provide some certainty in that regard. We'll also hear from Dr. Mostashari on the efforts that have been made by the Department of Health and Human Services to encourage the utilization of health information technology, and particularly the incentive payments that have been made to providers to adapt to new healthcare technologies. Recently, HHS announced that for this year, they hope to have 50% of the physician's office using electronic health records, with 80% of eligible hospitals receiving incentive payments by the end of this year. While the movement to increase use of electronic health records may seem like an obvious choice as doctors and hospital employees become more comfortable with new technologies, as a supporter of health IT, I'm concerned that the promised benefits of electronic medical records have yet to arrive. I personally heard from physicians in my district who've struggled to adapt or receive unclear guidance from the agency. A particular concern are complaints that systems in place are unable to share information with other systems. I hope our witnesses today will be able to address these concerns over interoperability. I'm encouraged by the work this committee has done this week. We've had a great dialogue on these issues, and today I hope we'll be able to hear the administration's view on its approach to innovation and regulation of healthcare technologies. I also want to apologize ahead of time. I have another hearing that I have to testify, and I'll be leaving a little bit, but will be taken over by the capable hands of the Vice Chairman, Dr. Mike Burgess. And now I'd like to recognize Ms. DeGette for her opening statement.
Thank you very much, Mr. Chairman. Mobile medical apps and electronic health records are developing at a rapid pace, and they have the capacity to transform the patient-doctor relationship, improve healthcare quality, and also to save billions of dollars. And I'm looking forward to hearing from the FDA and HHS about the efforts to integrate these new technologies into the healthcare sector. Dr. Madashari, I want to welcome you, the National Coordinator for Health Information Technology. The 2009 stimulus bill contained billions of dollars to help incentivize doctors and hospitals to implement meaningful use of electronic medical records. That investment has already made a big difference. Since 2009, the use of electronic health records by physicians has doubled from 20 to 40%, and the hospital adoption of electronic health records has more than tripled. More than 230,000 healthcare providers have qualified for payments for implementing the use of electronic health records. Ultimately, the adoption of these records will reduce medical errors, save money, and most importantly, improve the quality of care. Earlier this week, the Premier Healthcare Alliance reported that 333 hospitals in their network had since 2008 saved $9.1 billion and avoided 92,000 deaths by implementing a set of patient-centered quality improvement reforms that was made possible in part by enhanced data sharing and use of health information technology. But the transition to electronic health records is not without challenges, and Dr. Madashari, I'm glad you're here to address questions about the agency's roadmap to help us fully implement health IT. Ms. Foreman, I also want to recommend to welcome you to talk about the FDA's role in regulating and approving mobile medical apps. Mr. Chairman, I've got to admit the discussion of FDA's role in regulating medical apps seems a little redundant. This is the third hearing that has focused on these issues, as we heard. During the first two hearings, the other subcommittee heard from 11 different non-government witnesses about how the administration is balancing the need to promote innovation in this field against the need to protect to ensure patient safety. Those witnesses, thankfully, already debunked some of the biggest myths that we have heard from the outside about the FDA's role. Thank goodness, the myth of the iPhone tax has now been put to rest. We also learned from the witnesses that smartphones and tablets are exempt from the Affordable Care Act's medical device tax. We learned that the FDA is not currently and does not intend in the future to regulate smartphones or tablets as part of its regulation of mobile medical apps. We also learned that the FDA does not intend to regulate calorie counters or pedometers or other kinds of similar apps as medical devices. But we also learned about how the agency has a role in ensuring that other medical devices, like monitoring blood glucose or providing other vital medical information, are accurate and work the way they're supposed to do, which is exactly what the FDA is there for. But the committee also heard from some industry witnesses expressing concerns about the FDA's regulatory efforts and worrying that they could overreach and limit innovation. These concerns are not new, and they are not specific to mobile medical apps. FDA, and frankly this committee, has to constantly address this balance, whether the agency is regulating food, drugs, traditional medical devices, or these apps. That's part of what we have to do. The FDA addressed all of these concerns in a letter that was sent to the committee yesterday, and Mr. Chairman, I'd like to ask that the letter be made part of the hearing record. The letter makes it abundantly clear that the FDA will not tax your iPhone, and it provides new information that shows for the mobile medical apps FDA has reviewed, those reviews are moving quickly, taking an average of only 67 days. So to me, that sounds pretty much like an agency that's trying to foster innovation while at the same time ensuring that patients are safe. And so, Mr. Chairman, I don't think that the debate over how to balance patient safety and innovation will end anytime soon, but I'm hopeful that at least we can have a common understanding of the facts with regard to electronic health records and mobile medical apps, and we can continue in our joint effort with the agencies to make sure we balance innovation and safety. And with that, Mr. Chairman, I yield back and thank you.
Thank you. And we do have a copy of this letter for the record, but I thank the ranking member for bringing that up again. I now yield to Dr. Burgess for 5 minutes for opening.
I thank the chairman, and certainly we've heard from a number of qualified and distinguished scientists and specialists in medical technology and the communications industries over the past two hearings, and today we're going to hear the perspectives of the agencies that wrote the proposed regulations guiding these industries. The emergence of mobile medical technology does hold great promise, not only for lowering the care costs, but most importantly for improving health outcomes. The increasing availability of these technologies has revolutionized how providers interact with patients. We're at a point now where the number of providers using these devices has increased, almost doubled from a year ago, such that now nearly 2/3 of providers are using some type of device. The rapid proliferation of these new technologies also raises legitimate concerns about patient safety, but we also want to encourage important advancements that can improve patients' quality of life. And it's not just the overregulation by the government, but it's the uncertainty of pending regulation that also drives some of this discussion. The FDA struggles to maintain their current regulatory charge, but we need to be assured that they have the experience, that they have the expertise to handle the additional responsibilities of an emerging market. Ms. Foreman, I would like to thank you and your agency for the rapid response to the letter earlier this week. I hope that sets a new benchmark in the administration. We are accustomed to waiting years for a response, and this was indeed refreshing that it was only a few weeks in turnaround. And certainly we look forward to similar quick turnarounds for the final regulations of the draft guidance, which was issued in July of 2011. And Dr. Mastashari, I have enjoyed visiting with you in the past, and I thank you for being with us as well. As a provider, I have direct experience using health information technology and seeing the benefits as well as some of the downfalls that it brings to both patients and providers. Artificial barriers do nothing for care coordination, for patient safety, or for provider communication. As a physician, my primary concern is the health and safety of the patient. Inaction is not an option on this issue. However, we must do so in a way that encourages the development of innovative technologies, and we certainly do not want to push them outside of our borders. I'll now yield the balance of the opening statement time to the gentlelady from Tennessee, Ms. Blackburn.
And I thank the gentleman for yielding, and thank you, Mr. Chairman, for the hearing, and to our witnesses, Ms. Foreman, Dr. Mastashari, we thank you for being here with us. The hearings that we've done this week, I think are essential. I don't think they're redundant. I do think they're essential to getting our arms around an issue that we're going to have to deal with on the mobile medical apps. And I would say that one of the things that has come forward through the testimony we've received is that a 40-year-old FDA statute is not nimble enough to address the needs that are in front of us with this new innovation sector. I do think that ONC has a unique perspective on these HIT issues, and along with input from the FDA and from stakeholders, that Congress can find a path forward on what a framework would look like. One of the things we have heard from the innovators is the uncertainty that is there within FDA, this big gray area of whether you will or will not be regulated. That is stifling innovation, and as we heard on the hearing on Tuesday, it also does not do anything to provide certainty to investors who are going to be there. So that is of concern to us. Now, Dr. Burgess mentioned yesterday that these are the tools of today's doctors and future doctors, and 15% of these apps that are out there, the 97,000 apps, mobile medical apps, 15% are used by physicians. This is a way for us to achieve efficiency. It is a way for us to expand access. And what we want to be certain is that our innovators know with certainty what their classification would be, how they would be dealt with as an industry. So we thank you all for the testimony and for being here, and we look forward to concluding our series and finding a way forward on the issue, and I yield back.
I think I now recognize the ranking member of the full committee for opening statement, 5 minutes. Mr. Waxman.
Mr. Chairman, we're here today for the third day in a row to discuss electronic health records and FDA's regulation of mobile medical apps. And I'm surprised at the amount of time and attention given to this issue. I have attended the last 2 days of hearings, and from what I've heard, the members on your side of the aisle seek to answer two basic questions. Question one, whether the FDA is regulating mobile medical apps with too heavy a hand. Is the agency impeding innovation and harming this market by regulating too aggressively or approving mobile medical apps too slowly. This is not a new responsibility for FDA. For over 100 years, the agency has been balancing patient and consumer safety with the need for innovation. In the case of mobile medical apps, the answers that we heard in the first 2 days of hearings indicate little by way of concern. The witnesses told us that they understood the role of FDA and the need for agency regulation and were unable to point out any legitimate examples of apps that FDA was improperly regulating under its draft guidance. Although they had some anxiety about it, they had nothing to point to. Question 2 is whether FDA will impose a new tax, the Affordable Care Act's medical device tax, on your cell phone. The answer to this question is as plain as day. The answer is no. The Affordable Care Act itself contains a clear retail exemption. Even if a cell phone was designated to be a medical device, the Act says that any device that is, quote, generally purchased by the general public at retail for individual use, end quote, is not subject to the tax. That exemption would apply to any cell phone you can buy at a retail store. And FDA has been clear that the agency is not currently regulating and does not intend in the future to regulate smartphones or tablets as part of its regulation of mobile medical apps. The IRS has provided similar indications. Mr. Chairman, this tax issue is a non-issue. We did not need to spend 1 day of hearings on this, let alone 3. This committee could have used this time more wisely. I've asked you to hold hearings on the abuse of tax and regulatory loopholes by the tobacco industry and their efforts to undermine the Tobacco Control Act. Ranking Member DeGette and I have asked for hearings on the impacts of sequestration on the agencies of our committee's jurisdiction. We've asked for hearings on the risks associated with antibiotic-resistant bacteria, a very serious and growing public health threat. We've asked for you to hold hearings on Lifeline, the Universal Service Fund's low-income phone program. These hearings could examine the expenditure of billions of dollars of consumer funds. In the last 2 years, I have sent over 20 letters asking for hearings on the impacts of climate change, and we have not held a hearing on a single one of these important issues. Mr. Chairman, I hope you can understand our concern. I don't mean to discount the importance of mobile medical apps and electronic health records. This is an industry that, thanks to the investment we made in the 2009 Obama stimulus bill, is growing, is creating jobs, and has the potential to dramatically improve healthcare quality and save billions of dollars in healthcare costs. But there are too many pressing issues before us for this committee and this Congress to get bogged down for 3 days in what amounts to an inaccurate talking point about FDA overregulation and a non-existent iPhone tax. I hope that in the future this subcommittee can use its time more wisely. I must say, Mr. Chairman, for this particular subcommittee, I thought that the first hearings we've held under your leadership have been very worthwhile, and we can go back to doing things that are constructive and not just talking points for political purposes, which that's all these 3 days have been about. Yield back the balance of my time.
Thank you very much, Mr. Waxman. I'd now like to introduce Christy Foreman. She's currently the Director of the Office of Device Evaluation for the Centers for Devices and Radiological Health for the Food and Drug Administration. Before being named to the director position, she served as a Deputy Director for Science and Regulatory Policy in the Office of Device Evaluations. I'd also like to introduce Farzad Mastashari. He currently serves as National Coordinator for Health Information Technology within the Office of the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. Farzad joined the ONC in July of 2009. You are aware that the committee is holding an investigative hearing, and when doing so has had the practice of taking testimony under oath. Do you have any objections to testifying under oath? Both witnesses have said they do not. The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? Both witnesses have said no. In that case, if you please rise and raise your right hand, I'll swear you in. Do you swear that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? And if someone could work on the volume, I'd appreciate that, true. No, it's feedback from the volume. You're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute summary of your written statements. Ms. Foreman, if you'd like to begin.
Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, I am Christy Foreman, Director of the Office of Device Evaluation in the Center for Devices and Radiological Health, or CDRH, at the Food and Drug Administration. Thank you for the opportunity to testify today. I am pleased to be here to discuss issues related to health IT and to talk specifically about the actions FDA is taking to foster innovation in the field of mobile medical applications, also referred to as mobile medical apps. The widespread adoption and use of mobile technologies is opening new and innovative ways to improve health and healthcare delivery. Mobile apps, which are software programs that run on smartphones and other mobile devices, can help consumers and patients manage their own health and wellness, promote healthy living, and gain access to useful information when and where they need it. FDA believes it is important to adopt a balanced approach to mobile medical apps that supports continued innovation while assuring appropriate patient protections. We also recognize that mobile health application developers need a clear, predictable, and reasonable understanding of the agency's expectations. Now, while many mobile apps carry minimal risk, others can pose significant risk to patients if they don't operate correctly. In some cases, those risks are identical to the risks associated with an already marketed medical device. For example, a mobile app that affects the programming of a drug infusion pump or a CT scanner could lead to a drug or radiation overdose. An inaccurate or malfunctioning mobile medical app that diagnoses skin cancer could delay life-saving diagnosis and treatment. In July 2011, FDA issued a draft guidance announcing our intention to exercise enforcement discretion for most mobile apps. The guidance also clarifies that the focus of our oversight will be a small subset of mobile apps, which we refer to as mobile medical apps. These are apps that meet the definition of a device in the Federal Food, Drug, and Cosmetic Act and that are either intended to be used as an accessory to a regulated medical device or transform a mobile platform into a regulated medical device. Just as importantly as what our policy proposes is what our policy does not propose. It would not regulate the sale or general consumer use of smartphones or tablets. It would not consider entities that exclusively distribute mobile medical apps, such as the iTunes App Store or the Android market, to be medical device manufacturers. It would not consider mobile platform manufacturers to be medical device manufacturers just because their mobile platform could be used to run a mobile medical app regulated by FDA. It would not require mobile medical app developers to seek agency reevaluation for minor iterative product changes. And it would not apply to mobile apps that perform the functionality of an electronic health record, EHR system, or personal health record system. We have received more than 130 written comments on our draft guidance. The commenters have been overwhelmingly supported our narrow, tailored, risk-based approach, which we continue to receive many inquiries from industry stakeholders who are eager to see this guidance finalized. Some commenters have sought additional clarity on the types of mobile apps that would fall within the scope of enforcement discretion. Our final guidance will provide that additional clarity and examples. Pursuant to Section 618 of FDASIA, the FDA, ONC, and Federal Communication Commission have established a FDASIA Workgroup, which will provide expert input from a wide range of stakeholders to provide recommendations on an appropriate, risk-based regulatory framework pertaining to health information technology, including mobile medical apps. It is important to note that FDA has been regulating medical device software for decades, and medical device software on mobile platforms for more than 10 years. We have reviewed approximately 100 mobile medical apps, including remote blood pressure, heart rhythm, and patient monitors, and smartphone-based ultrasounds and glucose meter. We recognize the importance of using a balanced, transparent approach that fosters the development of innovative mobile medical apps while ensuring appropriate patient protections. We intend to strike the right balance by providing a risk-based, focused approach to the oversight of a small subset of mobile medical apps that present a serious potential risk to patients if they do not work as intended. We believe that focusing the agency's oversight will encourage the development of new products while also providing appropriate patient protections. Thank you for the opportunity to testify today about issues related to health IT, including mobile medical apps, and about the actions FDA is taking to foster innovation. Mr. Chairman, I commend the subcommittee's efforts and am pleased to answer any questions the subcommittee may have.
Chair thanks the witness. Recognize Dr. Moshasari, 5 minutes for your opening statement, sir.
Dr. Burgess, Ranking Member DeGette, distinguished subcommittee members, thank you for the opportunity to appear today on behalf of the Department of Health and Human Services. My name is Dr. Farzad Mostashari. I'm the National Coordinator for Health Information Technology. In 2009, HITECH was enacted as part of the American Recovery and Reinvestment Act. HITECH provided the resources and infrastructure needed to stimulate the rapid nationwide adoption and use of health IT, especially electronic health records, or EHRs. HITECH is working. The CMS Medicare and Medicaid EHR Incentive Program, the ONC-led certification program for EHRs, as well as the hands-on technical assistance provided by 62 regional extension centers, or RECs, across the country, are critical in facilitating unprecedented progress in EHR development, adoption, and use. There are now over 1,700 unique products produced by nearly 1,000 EHR developers and certified by one of 5 ONC-accredited private sector certification bodies. Adoption of EHRs has doubled among providers and more than tripled in hospitals. Electronic prescribing has increased 7-fold. RECs have signed up more than 130,000 primary care providers and over 30,000 practices. As of February 2013, more than 230,000 providers, nearly 43% of the nation's eligible professionals, and over 75% of eligible hospitals have earned payments for meeting the initial requirements of the EHR incentive program. Recognizing the need to strike a balance between the urgency of modernizing our healthcare system and the pace of change that can be safely absorbed, CMS and ONC have developed the incentive program in stages. Each stage is designed to add increased and advanced concepts. Published in July 2010, the Stage 1 final rules focused on functionality that support the electronic capture of data and its use to improve patient care, enhance care coordination and population health management, and increase patient and family engagement. The final rules for Stage 2 were published in September 2012 and represent an important next step with a focus on increasing standards-based health information exchange between providers and with patients. Even as we work to bring data and data tools to doctors and hospitals, we've also been encouraged by the pace of progress in the domain of consumer e-health tools. Increasingly, people are literally taking their health into their own hands. Mobile phones can be an incredible tool for empowering consumers to take control of their health, their care, their healthcare finances. And as we all know, more engaged consumers get better outcomes. ONC's strategy in consumer e-health is to work with partners to increase patients' ability to access their own health data, to increase the use of this data for actionable apps and services, and to shift attitudes around patient empowerment. However, we recognize there are risks as well as benefits to any technology. We must carefully balance the need for the widest possible innovation with protection of patient privacy, security, and safety. Over the past 4 years, we've worked with FDA and other departmental agencies on a risk-based approach to health IT that promotes innovation and avoids regulatory duplication. ONC advised FDA on the draft guidance for mobile medical apps. Where it concerns EHR technologies, FDA has advised us on a health IT patient safety action and surveillance plan, the draft of which was released on December 21st, 2012. The draft plan prescribes actions that all stakeholders can take within their existing authorities and resources, including safety requirements related to user-centered design, quality management systems, and easier reporting of adverse events in ONC regulations, use of ONC-authorized testing and certification bodies to collect complaints and conduct surveillance, working with developers to establish a code of conduct, working with AHRQ and patient safety organizations to improve aggregation and analysis of reported events, and working with CMS to train surveyors and use health IT to assist investigations. ONC has received public comments on the draft plan, and those comments have been generally favorable. On February 20th, ONC, FDA, and FCC announced the formation of the Food and Drug Administration Safety Innovation Act Workgroup under ONC's Health IT Policy Committee to provide expertise for the development of a congressionally mandated report on an appropriate risk-based regulatory framework pertaining to health IT broadly, including mobile medical applications that will further promote innovation, protect patient safety, and avoid regulatory duplication. We are now in the process of reviewing nominations. New technologies, including health IT and mobile applications, offer great promise to improve the quality of care and bring down healthcare costs. This doesn't happen overnight. To truly transform delivery, healthcare providers must also redesign workflows and re-engineer care. Payments must promote value over volume and care that is better coordinated and safe. Implementation of any program of this scale and complexity will inevitably include challenges. But by working within an open and transparent process, and in partnership with our public and private sector stakeholders, we can build on this strong start in bringing better care to all Americans. Thank you.
I thank the gentleman for his testimony. Before we start members' questioning, I do want to stress the importance of the members' questions and the importance of getting direct answers from all of you all. The importance of this questioning is reflected in the fact that the committee recently changed rules to limit member opening statements to provide more testimony more time for testimony and questioning. In order to make the question and answer period as productive as possible, I ask that you answer the questions in as direct a manner as possible. Some members will ask yes or no questions, and I ask that you limit yourself to a yes or no answer. I thank you in advance for your understanding. I'll now yield myself 5 minutes for the purposes of questions.
That's not part of the rules.
Would the chairman allow a question at this point? Is that part of our committee rules?
Stop the clock.
Yes.
Yeah, the part of the committee rules as adopted in the committee was to limit the opening statements.
Dr. Burgess?
But not the whole rest
Yeah.
of the stuff you said.
Dr. Burgess, I've been in this Congress for 8.5 years, not as long as you have, but I've never, ever, ever heard of a rule such as that.
It's not a rule.
Thank you.
Well, let me direct it as a courtesy then to the members of the committee that we keep our answers direct and to the questions at hand. Yield myself 5 minutes for questions. Now, we're here today, of course, to discuss the issue of the guidance that was produced in July of 2011. You proposed, Ms. Foreman, you proposed that the FDA proposed its mobile medical apps policy would not regulate the sale of general consumer or the use of smartphones of tablets. And certainly today we thank you for the certainty. Will the final guidance definitively say that the sale or general consumer use of smartphones or tablets will not be regulated by the Food and Drug Administration?
So it is not the agency's intent to change that position in the final guidance.
But, as everything, there is that possibility, and that's where the uncertainty comes from. And really, one of the things that the last 3 days or the last 2 days and today are all about is trying to provide some certainty for the people who work in this space and are making significant investments of dollars and time. And they're doing so because they think they have ideas that are ultimately going to help people. And we'd like to provide them that certainty. I think that's one of the reasons these committee hearings have been so important. Some of the uncertainty we've heard this week relates to the fact that the guidance issued in July of 2011 is a draft. When can we look for the final draft, the final guidance? When can that be released?
We have prioritized that guidance for publication this year. It should be coming soon with the intent of providing clarity to the...
Is your microphone working?
It is on.
Okay, pull it a little closer then.
We intend to finalize that guidance this year. It is a priority for the agency. It should be coming out in the final months. And the point of the final guidance will be to seek to clarify the questions received during the comment period and provide additional examples to clarify the agency's policy.
Did you say it will be coming out in the final month of this year?
No, it will be coming out in the coming months.
In the coming months. And when you say this year, you're talking about the calendar year, not the fiscal year?
It should be out before the end of the fiscal year, yes.
Okay, the fiscal year. Well, let's make a note of that. Some of the statements made by the FDA, either in the guidance or were made by you today, is the guidance going to be binding on the Food and Drug Administration? Are there situations where the Food and Drug Administration has deviated from its guidance when exercising its enforcement discretion?
So guidance is not binding. Guidance represents agency thinking. It is not a regulation. It is not statute. It is a lower level that represents agency thinking to provide clarity both to staff and to industry.
And again, I do want to, just for the record, thank you for your rapid response to that letter. Again, I do hope that sets a new standard for the administration in replying to letters from this committee. Historically, it can take some time to get questions answered, but these are important questions. These are questions not asked in a partisan manner in any way, shape, or form, and really trying to advance the science and the knowledge. Dr. Mostashari, I will tell you, I do get to travel to a lot of places in the country. I talk to a lot of provider groups, and I'll just say there is some concern. The FDA always looks to whether things are safe and effective, well, with the exception of tobacco, but always looks to whether things are safe and effective under its regulatory jurisdiction. But I can't recall that we ever saw the randomized clinical trials for electronic health records. Are those trials in existence? Were they done? Do we have that data?
Dr. Burgess, thank you for your question. There are many, many studies that have looked at whether when you try to improve quality, whether having information helps. And it's not something that perhaps is well suited to a randomized trial at the policy level, but the overwhelming evidence, and we have commissioned a study that looks at every published study on this, and while some of the negative studies, the ones that are counterintuitive, get a lot of press, the preponderance of the evidence is absolutely that when implemented appropriately, health IT is going to improve quality, safety, and efficiency.
And yet, I just noticed from your testimony, I mean, it was the end of last year, December of 2012, when your safety guidelines were published. The actual Ehrs stimulus bill was passed 4 years ago. The implementation began June of 2011, as I recall, and December of 2012 is when you're providing the safety guidelines. And you've stipulated such things as privacy and patient protections.
We have been, our belief is, and I think the evidence is, that the best thing we can do for safety in general is to get off of paper. And the evidence around computerized order entry, for example, reducing medication errors by 48% is clear. And we've seen an increase in e-prescribing that gets away from my handwriting and perhaps yours, which is a good thing in terms of improving the safety of prescribing. We just heard from the Premier system just this week about how they've saved $9 billion and 91,000 lives by implementing data-driven processes to improve care that can't be done in a paper-based world. So we believe that really getting healthcare into the data age is critical for improving safety. Now, as I mentioned, any technology.
Yes, sir. I'm actually going to stop you because my time has expired. In the interest of getting everyone heard, I'll yield to the ranking member of the full committee of the subcommittee.
Thank you, Mr. Chairman. I just have a few questions. Over the last 2 days of hearings before today, there was a lot of testimony and claims that app developers face a threat from the FDA, and that the agency is planning to regulate mobile phones and a wide range of apps, and then impose a medical device tax on phones. In the chairman's opening statement, I think he implied that he understands that the agency's not planning to put the medical device tax on phones. But I just want to clarify exactly what the agency is planning to do, Ms. Foreman. So I want to ask you a couple questions. Is it within the agency's jurisdiction to regulate mobile medical apps?
Yes, it is.
And can you give me, if you can pull that microphone even closer, I think you're a very soft-spoken person. Can you give us some examples of the types of apps that the FDA is trying to regulate?
So the apps that we are trying to regulate and that we have been regulating for a decade are similar to what is regulated through other medical device technology. A central monitoring station for a nurse that transmits patient data, heart rate, SpO2, other critical parameters for a patient that need to be monitored. We have ultrasound technology that there is an app and a transducer that can plug into a smartphone to allow ultrasounds to take place. Those are the types of technology that we're regulating.
And why are you trying to regulate those types of technology, Ms. Foreman?
So those types of technology pose patient risk. If the device does not perform as intended, there is the potential for patient risk. Additionally, it is the same as other medical devices we regulate. We regulate based on intended use, not based on platform. So just because a device moves to a mobile platform, it would not be the agency's intention that that would make it deregulated.
So you're not looking at how the app is used, you're looking at what the purpose is, right?
Exactly.
And this is an ability that the agency has had for some years. It's just not new under the Affordable Care Act or under the stimulus, correct?
That is correct. Our first clearance of a mobile app product goes back to 1997.
1997, okay. And can you tell me what types of apps the agency will not be regulating and why?
So there are apps that do not meet the definition of a medical device. The agency would not regulate those. That would be, for example, an app that takes an electronic version of a printed textbook. We have said that's not a medical device.
Okay.
There are devices that it meets the definition of a device, but the risk is low. The agency would rather focus our regulatory priorities on the higher risk products. So devices for maintaining a healthy lifestyle that help with
Pedometers.
Exactly. Yeah. We would not put regulatory oversight priorities into those products.
Okay. Now, in a different subcommittee the other day, members of the industry also agreed with what you're saying. Qualcomm's representative testified at that hearing, quote, "The FDA is squarely within its jurisdiction, and we took a lot of their initial actions as a very promising indication to the industry at large that they were willing to work with all of us," end quote. So, Ms. Foreman, I want to ask you, what are you doing to make sure that the agency doesn't overreach when regulating these devices and using the standards that you have set forth?
So as I mentioned, for us to regulate the product, it must first meet the definition of a medical device. That is what gives the agency its authority. But for all of the products that meet the definition of a medical device, we have actually narrowed our focus to a small subset of those. So we are actually refining our regulatory approach rather than overreaching.
Okay, now, so that's good that you're narrowing it down, looking at things that affect patient safety and so on, but we're still hearing concerns about the impact of uncertainty on the mobile medical device market. Can you tell me what the agency's doing to eliminate this uncertainty for investors and developers?
So we believe finalizing the mobile medical apps guidance is the first step in eliminating that uncertainty. That guidance will provide clear, transparent, and predictable messaging regarding mobile medical apps.
And that's the guidance that you told Mr. Burgess that you were planning to issue by the end of the fiscal year, right?
Correct.
Now, also, we've heard concerns about the effects of FDA-induced delays on the mobile medical device market. Now, how do you respond to those?
So we looked at our performance over the last 3 years, which we believe gives a contemporary performance. On average, it takes the FDA 67 days to review a mobile medical app. That's well within our statutory time frame of 90 days for the 510K process. All mobile apps we've seen thus far have been in the 510K process.
And you're going to continue that effort?
For the most part, yes.
Thank you. Mr. Chairman, I had referenced the letter from the FDA in my opening statement. It asked for inclusion in the record, and the chairman said he had received it, but I don't believe he agreed to my unanimous consent request to put it in the record. So I'd renew that request.
I also received it, and I accept your unanimous consent request,
it'll
so
be there.
ordered.
Thank you so much.
Chair recognizes Mr. Johnson from Ohio, 5 minutes for the purposes of questions, sir.
That's a terrific question, and you're absolutely right that it's the use of data, not just the data itself, that improves care. And as we found in other IT endeavors, IT becomes particularly important when you redesign the processes to take advantage of the information technology instead of merely digitizing the paper-based or former processes. And
I would certainly agree with you. You know, over my 30 years in IT, one of the cardinal lessons is just because something can be automated doesn't mean that it should be automated. It's an issue of business process re-engineering, and if you don't do that, you don't have a complete solution, or certainly you don't have a solution that's connected. So, who's developing the architecture that tells our healthcare providers and our system how this is all going to fit together?
We have developed that roadmap that you speak of, and it's an incremental roadmap, as you mentioned, through the stages, and it begins with making sure that we have data, because until you have data, you really can't see what you're doing. You can't have accountable care if you can't count, and that's where paper-based systems are today. So in stage one, the idea is let's collect the information in a structured way, because, yes.
That goes back to what I said earlier, and I think this is a discussion between two IT professionals here that everybody else may get bored with. That goes back to if you don't know where you're going, any road will get you there. I don't think you know what data you need until you have an architecture and you know what the end state looks like. You know, in the many software and technology programs that I managed throughout my 30-year career, if you don't start with an idea of what the end state looks like, then you waste a lot of money, you waste a lot of time.
That's right.
So I'm not sure data collection up front without knowing what data you want to collect makes a whole lot of sense.
Let me clarify my response.
Sure, because we start with data. Data doesn't become information until it's relevant and until it can be used. And data, just for the sake of data, as you know, is.
That's right. So
Go ahead, I'm sorry.
sorry about that. So we start with, in the meaningful use framework, we actually start with the end in mind. So we said, what is it about the use of technology that we can expect to improve safety, improve the quality of care, patient engagement, public health? And then we work backwards to say, okay, if we want to reduce deaths, unnecessary deaths, those are associated with better decision support at the point of care. It's associated with quality measurement and being able to make a list of patients by certain criteria, okay? And taking that a step back, you need to be able to have a list of medications for patients. That's pretty clear. You need to have a list of their problems and diagnoses. You need to know their allergies. You need to know their laboratory values. You need to know their blood pressure and smoking status. And it was those data elements, recognizing that as the system evolves, there will need to be flexibility and the ability to extend that framework and add, in the next iteration, devices, for example.
Like I said, people are probably going to get bored.
we would.
But how many physicians have been involved in the development of this roadmap and the kind of data that they need to?
We have one of the, I think, hardest working and most respected federal advisory committees in government. There are certain statutory representations on that. The House majority and minority leaders appoint members to the policy committee. The Senate minority and majority leaders, the comptroller general. It's a.
My time has expired.
Sorry.
The chairman is making that known. So I thank you for your answer. I'd love to talk to you more sometime.
And the
I'd
gentleman
love
may
that.
request that answer in writing, and I hope that he will. Chair recognizes
Will do.
now Mr. Waxman, Ranking Member of the full committee.
Thank you, Mr. Chairman. Ms. Foreman, we've heard a lot of allegations over the last few days that FDA is intending to regulate everything and anything digital or online that has any relation to healthcare. But the facts seem to be very different. I know you've attempted in your testimony, as well as in the 2011 draft guidance, to allay concerns about the scope of what FDA intends to regulate. But I'd like to, for the record, to go over some of the examples we heard in testimony yesterday or the day before. Is FDA currently proposing, or does it intend in the future to regulate ordinary smartphones and tablets?
No, it does not.
What about mobile platforms in general, such as the iPhone, BlackBerry, Android phones, tablet computers, or other computers that are typically used as smartphones or personal digital assistants?
No,
What about the entire mobile network?
no,
Each new mobile device released on the market?
no,
All health IT?
no,
An iPad application to help track the number of steps walked per day?
no,
An iPad application that reminds one that it's time to refill a prescription?
no,
Software that enables a physician to search a medical textbook?
no,
Apps to allow parents to access online services such as personal health records to document procedures their baby has undergone and drugs their baby was given?
no,
I don't think you can be any clearer. FDA has established limits on what it can and cannot regulate in the mobile device market, and I appreciate you walking through these limits. While I know that IRS, not FDA, implements the tax code, I'd like to ask you a bit about the recent claims that mobile platforms will be taxed under the Medical Device Act. Under the new medical device tax, will smartphones and iPads now be taxed as medical devices?
So the FDA is a public health agency, not a taxation agency.
I
Those
understand.
questions would probably be best answered by IRS or the Treasury, but my understanding is no.
These type of products are exempt from the medical device tax. Isn't that correct? Can you explain a little bit about this exemption?
So as I said, we're a public health agency,
Yes.
not a taxation agency, but they would not be regulated as medical devices, therefore not subject to the medical device tax.
Okay. As I understand it, they'll be exempt because FDA will not define them as a medical device. And even if you did define them as a medical device, they won't be taxed because they will qualify for the retail exemption. The law says items sold to consumers by way of retail cannot be taxed. Isn't that your understanding as well?
That is my understanding.
Although we don't rely on you for tax information.
You really should not.
But we're interested in this issue because it's been brought up so many times, and this committee is not a committee that has jurisdiction over tax. I thank you very much. It's clear that fears that iPhones and other smartphones are going to be regulated by FDA and taxed as medical devices are unfounded, and we can put this myth to rest. Over the course of the last 2 days of hearings, do you want me to go into this? Okay, well, Mr. Chairman, my staff informs me the next question is not for me to pursue, and I've asked the questions that I think are important, and I think they're a good way to end the third day of hearings to allay a lot of the fears that have been raised in the other two. And so, unless anybody wants my minute, I will yield it back.
And the chair thanks the ranking member, who's forever in his debt. Now yields for 5 minutes to Ms. Elmers from North Carolina.
Okay, thank you, and Dr. Mostashari, good to see you again. We've worked together many times on this issue, and there again, thank you for coming. Thank both of you for coming to testify today. You know, one of the things, and I know we've discussed this in the past, is really the cost to physicians who are small business owners. And as important as we all know health information technology is, the cost being passed on to them. There are estimations of $15,000 to $70,000 for the cost of implementing IT. Also, there's the issue of the physician really being taken
overall, we actually have data from the National Center for Health Statistics where providers report that EHRs have, in their estimation, produced clinical benefit for their patients. It's 79%. And if you look at those who are using the modern systems and who've been using it for more than 2 years, and this is important because it takes time to get used to the systems, that rises to 92% of providers believe that in their practice, the electronic health records are providing clinical benefit to their patients.
Now, that leads me to my next question, because a lot of the software is incompatible with other facilities. So software that one physician may be using may not be the same software another physician, or the physician in the hospital
Absolutely.
not using the same. So getting back to, again, considering errors, considering the possibility of information not being exchanged adequately, but also considering cost, which is, of course, ultimately gets passed on to the patient, and we're always looking for good quality of care. What is going to happen when we are trying to integrate all those systems? Is this cost then going to be passed on to the physician again, and having to bear the brunt of that expense?
Making sure that the patient information is available when and where it's needed is one of our top priorities. And we could have, as some countries have done, have said, we're going to solve that problem by the government's going to buy the EHR system for the whole country. That's not the way we do things, right? We said the people who are best suited to make those purchasing decisions are the hospitals and doctors who have to live with the systems. But in order to make sure that they can talk with each other, then we need to have some standards. We need to have a certification program, and to evolve that certification program and to create consensus, industry consensus, private sector consensus around how we can have one doctor choosing one system, the other choosing a different system that meets their needs, but having those systems be able to talk to each other. That's the approach that we've taken, and the certification criteria for 2014 put a big step up in those requirements.
Thank you, Dr. Mostashari. Ms. Foreman, I do have a couple questions. We continuously are talking about, one, the FDA regulation issue, which is very important, but also the tax on the medical devices. In your opinion, or has the FDA looked at this as an issue, that it might actually be stifling some of the innovation moving forward with having a tax on medical devices?
So as I said, we're a public health agency. Our decisions are governed by public health. But our decision-making was based on balancing innovation and public health. We identified a large subset of devices that could be under enforcement discretion without our regulatory oversight. As it happens, those devices it may not be subject to the device tax. As was mentioned, there's a retail exemption as well. Products available at the retail, even if it is declared to be a medical device, is exempt from the tax. But FDA is a public health organization, not a taxation agency.
Chair recognizes the gentleman from North Carolina. 5 minutes for purpose of question, sir.
Thank you, Mr. Chairman, and I thank both of you for your testimony here today. Over the course of the last 2 days of hearings, and actually in Ms. Foreman's testimony here today, we have learned that FDA has proposed regulating only a very small subset of mobile applications. FDA's draft guidance states that the agency will only look at those mobile apps that are essentially acting as a medical device or as part of one. The guidance also explicitly exempts many of the apps that my colleagues on the other side have been trying to scare people into thinking FDA was going to take over, things like electronic PDRs and electronic health records. And that seems like a very reasonable approach to me. But I want to learn more about exactly what kind of regulatory burden we're talking about, even with this small subset of applications that will be regulated as devices. I know that an FDA-regulated medical device may fall into one of 3 tiers. We've heard about that. Class 1 devices are the least risky devices, while Class 3 devices are the most risky. And so let me start with Ms. Foreman. Ms. Foreman, can you briefly elaborate on these 3 levels of device oversight and explain what responsibilities a device manufacturer has under each of these levels?
Certainly, I'll start at the bottom and work up. So if the device is a Class 1 device, which the small subset could have devices that meet the Class 1 definition of a medical device, they are not subject to agency pre-market review. They are subject to meeting registration and listing requirements as well as the quality system regulation, making sure that they've manufactured the devices properly. Moving up to Class 2 devices, they have to meet those same criteria, registration, listing, quality system, but they also need what's called a 510K or a pre-market notification. That application would allow the agency to review and clear the device as equivalent to another device on the market. There's a user fee associated with that. It's just under $5,000. However, if it's a small business, it's half of that. If they make significant modifications to the device, they would need a new 510K, but as I've mentioned, we plan many of those iterative changes to not require new submissions of 510Ks. If we move up to the next level, Class 3, that requires a pre-market approval application. To date, we have not found a mobile app that would fit under that bucket. Not saying that in the future it wouldn't be possible, but we have not seen that yet.
So essentially what you're saying is that a Class 1 or 2 device doesn't have to do all that much in terms of pre-market clearance, while Class 3, if there is one, sounds like it may be subject to more stringent requirements if one evolves.
Correct.
Is that correct?
Correct.
Okay. Now, which level of regulatory oversight will most of these medical applications fall under?
Class 1 or Class 2?
Class 1 or Class 2? And you don't know of any Class 3 existing at this moment?
I do not.
All right. Now, Ms. Foreman, there were also some assertions yesterday that FDA lacked the expertise to regulate mobile applications. Your testimony states that you have regulated medical device software for decades and mobile apps for more than 10 years. Can you elaborate on FDA's experience regulating in this area?
Absolutely. This is not new for the FDA. We've been regulating software and mobile apps for some time. When we do our review, we actually bring together two different sets of expertise. There's the software expertise that we have software engineers who will review the software information to make sure that it was developed properly. That's coupled with a clinical review because the app is intended for a medical application. So for example, if you take an app to view a radiology image on a smartphone, the software reviewer can make sure that all of the technical specifications happen properly on the smartphone. But what we will bring the clinical reviewer in to look at is, so if we view an image on a smartphone, can we actually detect cancer with the same level of sensitivity and specificity that we would on a large view station? So you can zoom the image, you can pan, you can look at it that way, but is there a difference between looking at the whole image versus pieces of the image to make sure that patient safety is not compromised, because you don't want somebody to have undergone radiation for a diagnostic purpose and then that purpose is there's a false negative or a false positive.
Can you finally address how you plan to keep up with the world in which so many apps are already on the market and so many new ones are coming out every day? How are you going to keep up with all this stuff?
So as we mentioned, part of keeping up with it is prioritizing our focus. So we are prioritizing our focus on the small subset. We get about 20 a year. Right now we're getting less than 20 a year. That is actually in our 510K inventory. That is about 0.5% of the medical device applications that we review. And keeping up with technology is something that we are always faced with. So that's why we bring on competent staff and we make sure we try and provide training opportunities for those staff so that they can continue to stay abreast of the latest technology.
Thank you. My time has expired.
Gentlemen's time has expired. I'm advised that votes have been called. We'll try to go and get through as many of the panel as we can. Recognize the gentleman from Missouri. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you all for being here today. Director Foreman, have a question for you as far as current FDA risk evaluation and mitigation strategy, REMS for short. Their guidance requires, doesn't it, that medication guides upon first dispensing of the medication, and then for every subsequent refill, you have to have the medication guides printed out. Is that correct?
So I'm going to apologize because REMS is a provision implemented by CDER, our Center for Drug Evaluation and Research. So that's really outside of my area of expertise in the Center for Devices and Radiological Health.
Okay, who should I go to to answer that question? Who should I?
CDER is headed by Dr. Janet Woodcock.
Okay, okay, because that was my intent, was to ask if on a refill prescription, if that could be able to be handled through a mobile device as opposed to trying to mail a stack of how to retake your medicine every time that it's prescribed. So with that, and I know we're short on time, Mr. Chairman, I yield back.
Gentleman yields back. The gentleman for New York is recognized 5 minutes for questions.
Thank you, Mr. Chair. Dr. Mastashari, there is a broad consensus that the increased use of electronic health records and health information technology ultimately leads to better patient care and a bending of that cost curve and savings. There's also a concern that the adoption of these EHRs also provides an increased opportunity for fraud by exaggerating the intensity of care or severity of patients' conditions on their Medicare claims. We've, I guess, labeled this as upcoding, and it's often facilitated by software programs that prompt billing for additional services that were not provided and may be only tangentially related to the care received. Many of our health IT vendors are developing these systems to promote their products as a way to increase the bottom line. So my question is, can you discuss what your office is doing to develop guidance and technological standards in electronic health records software that will help to prevent this type of fraud?
Yes, thank you for the question. I want to make one thing very clear, which is that if there is documentation of care that did not occur, that is fraud. And CMS and the Attorney General and the Secretary of Health have made it very clear that we will not tolerate fraud. And the electronic health records provide increased tools also on our side to be able to better investigate and prosecute a fraud should it occur. There are always those who will attempt to defraud the system, and I think this administration in particular has been very successful at and has had record prosecutions and recoveries under that. But I think your question gets to also issues where it's not explicit fraud, and those are more complicated situations. I think some of the analysis that's been done looked at patterns of coding intensity over the past decade, before the first meaningful use payment check ever went out. For a decade, there's been this creep towards higher intensity codes. CMS, this is not a new issue for CMS, and they have ways of dealing with shifts in these patterns. But the electronic health records that were formerly predominantly used for documentation and billing purposes before meaningful use, that may have been part of the business case for them. I think that our challenge is twofold. First, to make sure that we get the broadest possible input on ways that we can mitigate any possibility of the record systems themselves inducing inadvertent violations. The second is to make sure that the systems meet the needs of the future, which is, as I think there's broad consensus, means moving away from paying fee-for-service based on documentation and more towards outcomes and value.
Thank you. And what lessons can be drawn from the implementation of EHRs nationwide from the VA's long successful track record with VISTA, their Veterans Health Information System and Technology architecture program, specifically in terms of interoperability and usability of records?
It's interesting, following on your previous question, one of the groups that had the most experience with the perils of copy and paste was the VA, which, even though there was no billing incentive, it was convenient to carry forward notes from before, and it resulted in it's not a billing issue, it's a clinical documentation issue where it wasn't easy to understand. If you practiced at the VA, sometimes you saw notes that were copied forward and forward and forward, and it wasn't good for clinical care. You couldn't understand what was really going on with the patient in this visit. And the VA has done a lot, working with clinical leadership to say, how can we improve the quality of the clinical documentation and the usability of the systems? The VA, there's very strong evidence that they have saved billions of dollars by implementing IT and by continually improving the systems that they have. And if there's one lesson I would take from the VA, it is that no system is perfect the day it's implemented. And it becomes improved over time through the polishing of that stone, through the application of clinical judgment, improved usability, improved interoperability, and that's what we're engaged with here. This is not a, one and done process. This is going to be a continual process of refinement, optimization, improvement, and redesign.
Thank you, Dr. Mastashari and Ms. Foreman, for appearing before us. And Mr. Chair, with that, I yield back.
Gentleman's time has expired. Chair now recognizes Mr. Griffith for 5 minutes for questions, sir.
Thank you, and I apologize to the witnesses in advance. I have to move fairly quickly, so I'm cutting through a lot of the explanation because I think you all know where we're heading on the questions as we get to it, but if you need further, let me know. Ms. Foreman, your testimony notes that questions about medical device tax should be directed to the IRS, but clearly they're going to need help in figuring out what is a medical device or what you are regulating as a medical device if it's the purpose of it and not the platform. And so I would ask, have you had any discussions with the IRS about this tax, about the tax, if they asked for your input on that?
We provided technical input to the IRS on the interpretations of our laws. The way it was implemented is that if a medical device lists, it would be subject to the tax.
And can you provide us with a copy of what you gave the IRS so we can take a look at that to the committee? Not today, but subsequently?
I can look into that.
Okay, thank you. And has the FDA done any analysis on the impact of the tax, either in dollar figures or the number of manufacturers it will have an impact on?
FDA is a public health agency. We are not involved in the taxation. We receive no direct benefits.
In regard to the questions the list of examples that Mr. Waxman listed out, while the FDA does not currently have any plans, do you believe that the FDA could, if it so chose to do so, regulate those examples down the road if it had a change of heart?
So if the device meets the definition of a device as defined in the Food, Drug, and Cosmetic Act, we could. We have no intent to. The only thing that would change our mind is if there was a strong safety signal that we became aware of a device that we were not regulating appropriately under enforcement discretion by not regulating it. That would cause us to reconsider our position. But absent strong safety signals, no, we would not change our mind.
All right, and then the practical question that I would have is, if somebody is currently developing an app of a medical nature, how do they know, or how does anybody know, if they're supposed to be contacting the FDA? And I just, I'm just an old country lawyer, and I got on my tablet here, it's an Android, and found an article yesterday, and there were lots of them. I just chose this one because it sounded interesting, that the iPhone is now a handy tool for detecting and diagnosing parasites. And the article says, using little more than an iPhone, strips of double-sided tape, a cheap ball lens, and a battery-powered flashlight, a workable model was assembled to determine whether or not a child had parasites. Y'all regulating that or not?
To my knowledge, we have not regulated that. It has not come before us. A diagnostic device, though, would meet the definition. That would.
So if the Canadians, the Bostonians, and the Swiss who worked this up to help in other countries decided that it might be helpful in rural parts of the United States, they'd have to come to you first, and instead of costing $8, it would cost what? Hundreds of thousands?
We are not involved in the pricing of medical devices.
No, I'm not talking about what the price is. I'm talking about how much it costs to get it approved.
So as I say, a 510K fee is just under $5,000. If it's a small business, it would be half of that.
Okay.
So $2,500.
But you'd want all kinds of tests and studies, not the fact that they've been out in the field and made it work with double-sided tape. Am I not correct?
I'm not inherently opposed to double-sided tape, but
Understand. I think I've made my point, and I yield back my time, Mr. Chairman.
Thank the chair. Chair yields to the gentleman from Texas, Mr. Barton, for questions.
Mr. Chairman, I appreciate the time. I want to yield it to you to use as you so decide.
Well, I thank the Chairman Emeritus. Dr. Mastashari, I just have to ask you here as we conclude today. We hear a lot of stuff about interoperability. I mean, you're the head. Why don't you just fix that? Why don't you just make that happen?
We are using every lever at our disposal to increase the sharing of information, and that includes not just the data standards and getting industry together to help us. We don't want to be the ones to say, we'll choose the standards. We really want to work with industry to get consensus and to accelerate this.
But, you know, in the interest of time, we do hear about this a lot. Even anecdotally, hospital systems in the same city that have the same operating system aren't talking to each other. Seems like you could make that happen.
The 2014 certification criteria, Dr. Burgess, I would be happy to go into great detail with you, but they are a big step forward, and I believe that hospitals and doctors around the country will see a palpable difference once those certification criteria are in place.
Well, I want to thank both of our witnesses for being here today and for bearing with us. Apologize about votes cutting the hearing short. Dr. Mostashari, I look forward to having you back at either the Health Subcommittee or this subcommittee in the future. You're a fascinating witness. We've learned a lot this morning from both of you, and I appreciate your time. I want to thank the members for their devotion to the hearing today. The committee rules provide that members have 10 days to submit additional questions for the record to the witnesses. I also failed to ask for unanimous consent that all member statements that wish to be entered in the record be entered. Hearing no objection, so ordered. The hearing stands adjourned.